So just a very quick definition of this. This was patients, again, very high-risk disease. And this was a different population here in DB05. These were patients that were considered upfront inoperable. So they had clinical T4, any nodal status, or they were clinical T1 to T3 with N2 plus disease. And so again, very, very high risk, or they had pathological nodes positive after they had received neoadjuvant therapy. And so then these patients went on in a very comparative Catherine approach to receive 14 cycles of T-DXd versus 14 cycles of T-DM1. So the invasive disease-free survival was 92.3% with the use of T-DXd in the adjuvant setting. So very exciting data in that space. Trends towards overall survival, brain metastasis-free interval improvement. Again, early days in those regards, but again, very, very encouraging results. So tell me about your opinions about this data, how it might inform your practice in certain patients, your general thoughts on the data.
I think this is practice changing. I really would not have any qualms about offering these very high-risk patients T-DXd in this setting. Of course, you know, the challenge is who should receive it preoperatively, as we've been discussing. But for those patients where they've already gone through surgery and now there is residual disease, especially in lymph nodes, it's breast and or lymph nodes. So it's a bit different in terms of how we were using T-DM1, right? With that being said, I think it's important to call out that the label is very broad in terms of how you can consider using it. And here's where I think our clinical judgment has to come in quite a bit. I think that for those patients that meet the criteria on the trial, those are the ones that I'd be more considering offering T-DXd in the adjuvant setting. The nice thing that we did see was this trend in lower numbers of CNS events, but by no means was it a home run, right? Because if you look at the numbers, they're very small. So 25 versus, I think, 17, 40% of those recurrences were still in the CNS, and this is an area of unmet need. Of course, there are ongoing trials like Compass RD, looking at the incorporation of a tyrosine kinase inhibitor in that setting that can hopefully impact that outcome. But for patients that meet the criteria of the trial, I'd be very comfortable in offering them T-DXd. Of course, the toxicity profile, as we think of the ILD rate, seems to be higher when it's driven by the duration of exposure, right? 14 cycles as opposed to 4 cycles. And we saw ILD rates that were closer to 10%, which is along with what we're seeing accordingly in the metastatic setting. Trials, so, of course, all of this factors in for the individual patient.